Welcome everyone to our next session in our Boosters and Beyond series, specifically focusing on dementia care and antipsychotic medication use. Today we have Dennis, Dennis and Amy, who are our esteemed speakers for today's session. But before we get into that, I'd like to get through some housekeeping items beforehand. So if you're not familiar with who we are the iPro QIN-QIO. iPro specifically holds the federally funded Medicare QIO contract for the regions shown here. iPro helps support specifically New York, New Jersey, and Ohio. Health-centric advisors help support Connecticut, Maine, Massachusetts, New Hampshire, Rhode Island, and Vermont. And Clarent helps support Maryland, Delaware, and the District of Columbia. Together, we are 3 organizations under the iPro QIN-QIO banner. So if anyone asks if you know who iPro is, or Health-Centric Advisors, or Clarent, you say yes. At this point, I'd like to pass it over to Mary Ellen to give us an update on COVID-19. Thank you.
Thanks, Josh. So hi, everybody. So hospitalizations again are down this week, 6.2%. There's 2.17 cases per 100,000 of COVID-19 admissions. The bivalent booster data is unchanged from May 10th, and I think that's a reflection of the public health emergency ending, that they're not updating that quite as frequently. So we'll keep a watch on that to keep you guys updated. The latest variant, still the XBBB strain, is the most dominant, and the 1.16 strain has increased with cases causing 18.2% of cases. So it no more severe, but continues to circulate. Next slide. So similar to the influenza graphics that you're used to seeing, CDC is posting a map similar to influenza tracking for COVID-19 new hospital admissions. And as you can see, everybody's really in a low admission level status for the country, where there's pockets of medium to high or increased hospitalizations. But for the most part, they've been low and continuing to trend low across the country. And this is important for folks if you're an IP that's has been used to seeing the data from the number of cases before, and you're trying to figure out what's the threshold. That for some folks, they're taking their county or state hospitalization numbers and just watching them, so that in their own facilities there may be a threshold of how many hospital admissions you're seeing in your particular area that may start your COVID plan process, or however that may look. So it is useful data to kind of keep track of these and make a plan for your own institution. Next slide. And this, if you haven't seen it yet, and I will pop the link for this in the chat, this is an awesome tool. It is basically respiratory illness surveillance now that they've combined COVID, flu, RSV into a really nice customizable graph. You can look at it based on your age population, your state, your ethnicity. You can combine it so that you can look at COVID, flu, and RSV all together. And so I think going into the winter seasons, it's going to be a nice tool to use to really track everything all at once with a one-stop shop. And again, it has really user-friendly filters. So when you get a chance, check it out and see what you think. And that's it. Thanks, Josh.
All right, perfect. Thanks so much, Mary Ellen. So at this point, I'd like to pass it over to Dennis and Amy to get us started with today's topic. Thank you.
Thanks, Josh. So our learning objectives today are to understand that behaviors and expressions are just methods of communication, to evaluate facility antipsychotic use related to regulatory requirements and the guidelines, recognize the roles of nursing assistants, activities, and other staff in reducing antipsychotic use, and list ways that family members can contribute to reduce anxiety and aggression amongst residents with dementia. Next slide. So it is crucial and important to ensure that all team members understand the rationale for reducing antipsychotic medication use. Each of the team members has a very important role to play in understanding the resident with dementia and learning their triggers and avoiding triggering them by using non-pharmacological interventions. Next slide.
So I want to point out again that Josh said we are esteemed speakers. On that. Okay. So
He was
we
talking
are,
about me.
okay. So we are discussing this topic. And we've been discussing, for several weeks, dementia and the use of antipsychotics. And one of the things I want to pause and just talk about a little bit more is the fact that often we use medications and antipsychotics due to the fact that we use it as an intervention for quote unquote behaviors or expressions because they're upsetting to others as well as to the residents themselves. At times, the situation can escalate to aggression, anger, and even violence. And an effort to provide safe, quality care. So the goal is to prevent escalation. However, there is difficulty in defining behavior. Behavior is very open to interpretation by the person that's observing the resident or patient, and several different staff members may describe what's being observed differently. However, words actually, they really do matter. Here's a simple example. So if John's walking down the hall and he's talking loudly and he's gesturing with his arms and he's pacing in the hall, one person may say the patient's agitated and angry or anxious and yelling and disruptive, when in fact, he is just frustrated because he can't hear, he can't communicate because his hearing aid is lost. We don't know why someone is behaving a certain way, expressing things a certain way. So, especially because we don't know necessarily their life experiences or their current stress or emotional status. Generally, when our brain doesn't really understand what it sees, it's going to naturally fill in the story with something. We need to stop and pause and think and look at the facts, what's actually happening. Rather than giving meaning to something, let's just figure out what actually the person is trying to say. Also, there's different reasons that residents express behaviors or gestures. There's no real clear rationale. Different people believe it's different reasons. There's the biologic that is due to changes in the brain that in turn results in problem behaviors. Sometimes we think it's behavioral. Behaviors stem from a relationship between the patients and the environment, and the behaviors are in response to too much stimuli. Sometimes we believe it's reduced stress threshold. So individuals are acting out, or is it because of unmet needs? Bottom line, before we medicate anyone, we really should determine why and what we are seeing. What's the person trying to communicate? What can we do to mitigate that before we go to an actual medication? So next slide, please, Josh. I love the Swiss cheese model, and everybody makes fun of me for it. So James Reason is a quality improvement pioneer, and he developed the Swiss cheese model for quality improvement. And it's very helpful in describing certain issues. And when we look at it in terms of dementia and behaviors and medications, we really need to break it down and think to ourselves, well, before starting medications, we should first stop and consider what's causing the expression. And each one of these slices of cheese could be something else. So we should be pausing and saying, okay, have we addressed? Is there an unmet need? Does the person need to use the bathroom? Is there pain? Is the person hungry? Is there anything else that we can address before ending up with medication? And it's only after fulfilling all of those other possibilities that we should be getting to the medication portion. Next slide, please. So One area that may be an opportunity to improve for all of us is that if there's a resident having behaviors or expressions and they're on any type of psychotropic medication currently, and they're still having behaviors or expressions, this may be someone that you want to evaluate and see, should they really continue on that medicine? If they're on a medication and they're still having behaviors or expressions, then it's likely the medicine isn't working. Involve your consultant pharmacist, involve your consultant psychiatrist if you have one. And if it's safe, it may be appropriate to discontinue the medicine and try and take a team approach and look at some specifics regarding that resident, their past history, that behavior, that expression, and really evaluating everything. Next slide, please.
So we're going to talk about medication reviews and how they should be occurring, not just with the MDS schedule, but they should be done consistently and almost constantly. When conducting a medication review, there's many considerations to explore, like acceptable clinical diagnosis for the indication, whether it's a diagnosis for the condition and not for convenience, effectiveness and whether it's being monitored and what is the goal of the medication use, to monitor for changes that may be due to the medication use, monitor for potential adverse consequences. We want to ensure that the dose is appropriate for the appropriate length of time. And when we GDR, we want to be ensured it's done as required and that the documentation is thorough and easily found in the medical record. Non-pharmacological intervention should also be used and documented. Next slide. In visualizing the Swiss cheese model, which Janice so much loves, if a patient or resident is appropriate for the antipsychotic, our duty is to prevent harm. There are regulations and standards that are in place to try to assist with the prevention of harm or side effects. It's also important that the care plan is individualized for medication use with appropriate approaches to care and non-pharmacological interventions included. The resident is monitored for any signs and symptoms of distress, that the benefit of these medications outweigh the risks, that signs and symptoms are clinically significant enough to warrant the use of these medications, and that the pharmacist his medication review is thorough. With any change of status in a resident, the need for medication should be reviewed. Next slide. Once the antipsychotic medication is ordered, refer back to the state operations manual for specifics on the regulation related to the medication, policies, care planning, and quality assurance. And here's the state operations manual. Next slide. Included here are one of the tags in the state operations manual that relates to antipsychotics, but this is not the only one area that the antipsychotics are addressed. Here is specific regarding the chemical restraints, and the pages are included also. I'm not going to read the regulation, but it's important to share with you and your team so they understand why medications are not always the most appropriate first option. Next slide. Oh my God. The actual guidance in the state operation manual states, 1, any medication that impacts cognition or sedates or subdues and is not an accepted standard of practice for residents, medical or psychiatric condition may be a chemical restraint. 2, it may be a chemical restraint if there is less restricted alternative treatment or if the symptoms for use have subsided. And 3, assessment, care planning, and documentation must be thorough. These are additional points to share with your team. Next slide. Oh my God. It's important also from the state operations manual that should be shared with your team. 1, if the goal is to stabilize symptoms so the person can function at the highest level possible, and that means no symptoms, And when the medication is reduced or discontinued, the symptoms return, then reducing or eliminating the medication may be contraindicated. It must be individualized, and if it is not documented why it's necessary, it is assumed to be for staff convenience, and we don't want that. GDRs must be done to document that symptoms occur without the med and that the individual is better with the medication. Even though the symptoms may no longer be present, remember that the disease process itself is still present. For example, diseases may include chronic psychiatric illnesses like schizophrenia or schizoaffective disorder, bipolar, depression, or post-traumatic stress disorder. Neurological illnesses such as Huntington's or Tourette's, and psychosis and psychotic episodes. Next slide.
So yes, there's a lot of regulations if you're going to give the medication. The clinical record must also show documentation that the resident or patient has been evaluated and that underlying metabolic medical issues have been ruled out, identified, and treated. If you have a larger population of patients or residents with cognitive impairment, it's beneficial to possibly place them together in the same unit or hall and create a therapeutic or safe environment specific to their interests and abilities. At the end of the presentation, we're going to go through some resources for non-medication management. However, there's a lot of information available regarding what environment is most suitable and how environmental changes at certain times of day are beneficial. And Amy and I love this topic of conversation, so feel free to reach out to us at any time and we're happy to help you. Next slide. Along with all the other regulations and regulation sources that Amy went through, we also want to mention that the RAI manual, the resident assistant instrument that provides guidelines for the MDS, also provides clarification regarding antipsychotic medications and diagnoses. And there was an update done in July of 2022. And there's an anticipated update in October of 23. And in the July of 2022 update, there was quite a bit of focus on appropriate information to support a diagnosis for use of antipsychotics. So make sure your MDS coordinator is familiar with these changes, and I put the manual pages on this slide. Next slide, please. So because we're talking about the team and how everybody should be involved, and we've been talking a lot about the regulations and the guidance and everything. And, so far we've kind of focused a lot on the management and leadership. We really need to make sure that everyone in the facility is aware of our population with cognitive impairment and how that impacts their memory, their communication, and the quote unquote behaviors. So let me tell you about my little friend Carl. Let me first start by saying, imagine you're sitting at home at night at the end of the day, sitting in your recliner, like I'm sure we all do at the end of the day. We go home and we sit in our recliner and we put our feet up, and I'm sure we all enjoy a nice glass of water. And we're watching television and we're sitting in our recliner with our feet up in our personal space, and we're relaxing in our downtime and having our water. And while you're sitting there, someone comes in your space and they're moving around in your private area, moving your items, moving your belongings, moving around in your environment. Then they go into your bathroom and you hear more noises. Now you're trying to relax and this is your space and someone's moving around, moving your items, moving around in the bathroom. Then they come out and they leave with a bag and the bag is full. Well, what is your reaction? Your reaction is going to be anger, frustration, agitation, fear, anxiety, paranoia. Now your friend comes and says, let's go to lunch. And your reaction is, no way. Do you know what just happened to me? Or someone says, let's go to the spa. And your reaction is, do you have any idea what just happened to me? Someone came in my private space. They were touching my items. They took a bag of stuff. I've been robbed. And everyone's going to agree that you have every reason in the world to be upset. So now let's pretend you're Carl and you're sitting in your room in Happy Haven Nursing Home. And the same thing happens to you. You're Carl. Your feet are up. You're in your private area, your private stage space in the evening, relaxing, watching television. And someone comes in your private space, moving your items around, goes into your bathroom and leaves with a bag full of stuff. One of the things that's different with Carl is he has dementia. So he doesn't have a memory center, a hippocampus. He can't remember somebody was in his room or what he was doing. However, all those feelings are stirring in his belly. He's paranoid, he's angry, he's frustrated, he's fearful. Now somebody comes in and says, Carl, let's go to dinner. No, I don't want to, is his response, of course. So Susie, the CNA, goes out to the nurse and says, Carl's non-compliant. He's having behaviors. Let's call and get him medication. And someone else comes in and says, Carl, it's your shower day. Do you think Carl's really in the mood for a shower? No. And he's angry and he's agitated. Of course he is. If we just backed up the day a little bit and looked at the camera to see what happened before Carl became upset, we would see Fred, the housekeeper, had gone in his room, cleaned his room, and emptied the garbage. There was a reason Carl was upset. We need to involve the entire team, educate even the non-clinical staff that when they go in and interact with somebody with cognitive impairment, introduce yourself. Say while you're there, I'm here. I'm going to clean your room. Carl's not going to remember, but he's not going to be upset. Before Fred leaves, Carl, I've cleaned your room. I have your garbage. Now Fred can leave the room. Carl's not going to remember, but Carl's also not going to be upset. And more likely, he's going to be ready to go to dinner. So we really have to engage the team at all levels, clinical, non-clinical, and help everyone understand the memory impairment and how we can work with people with dementia. They still have a lot of abilities. So how can we work with those? Amy and I have been building a bunch of resources that we're happy to share with you to help you and your team. So next slide, please.
So now I get to talk about something that's not regulatory. But I mean, it is, but it's not. So care plans. So I worked in long-term care for like ever, but care plans in assisted living are very different than care plans in a nursing home. So when I went to the nursing home, I had an amazing mentor who helped me learn how to do care plans. And she always said, Amy, this is a living document. This changes as the resident changes. You always have to keep it up to date. This is the map to their care, their life, everything. So I always took that very seriously. So I love care planning where most people do not. So they are required for all residents, but they're specifically important for people with a cognitive impairment. It helps with communicating with the resident, what their needs are, what they do and do not like, how to best communicate with the residents, and it will tell the staff what upsets the resident and what calms down the resident. So while the important things are there, the dental, the ADLs, the medications and the diagnoses. Having your care plan perfect for this person, this cognitively impaired person who has no means to effectively communicate to you what they want or what they need is essential. It's vital. And they're individualized. So what you could have on Sally Smith's care plan that she likes, flowers on her table when she's eating, is not going to be the same as Fred's, who wants to listen to Elvis while he's getting ready in the day. So it's your opportunity to make it patient-centered, which it has to be, and provide your care staff a perfect map quest on how to take care of these people. You're also going to want to put in the signs and symptoms of the resident, what they display when they're getting amped up, and the medication and the side effects that everyone should be watching for. We want
Believe it or not, I was not the amazing mentor she's talking about.
no.
She had another amazing coworker.
I did. So if you guys ever want help with care plans and ideas and thoughts, Janice and Amy can do that too. Next slide, please. So as Janice had said, we are developing resources to help you guys and the facility and all of your staff with psychotropic reduction, not just antipsychotics, all psychotropics. In our resource library, we have an action plan with SMART goals and action steps to help reduce your antipsychotics or psychotropic use. We have educational resources and we're building more. We have a psychotropic review worksheet that we have worked with facilities in helping get the data in place and when doing MDS assessments for team review, and helps when you should have that individual see psych. And we are happy to meet with you to start your process. Next slide. Oh, Janice.
Now, next session, you get Amy and I again. Woohoo! And we're going to look at some dementia-friendly phrases that staff in all departments can use. We're going to talk about some systematic ways to do psychotropic reduction, as well as implement some dementia-friendly environments. We're going to look at some more of our iPro tools, resources, and how they can help with your processes, and talk all things dementia. And again, Amy and Janice are always here. So is everybody. But
sometimes I say to Janice randomly, Janice, I just want to go home. I just want to go home. I'll interrupt her.
It's great. Next slide, please. And then we have a whole list of places where you can get non-pharmacological interventions. AHRQ as areas, and we do have on our resource library a page full of, and Rob shared it last week, a resource page of best practice, evidence-based practice areas where you can go for non-pharmacological interventions like AHRQ, IHI, dementia.org, and Alzheimer's Association. Next slide. So if you need anything, we are iPro. We are on Facebook, Twitter, LinkedIn, and YouTube. Anything else, Josh?
No, that is it. Thank you so much, Amy and Dennis. What I'm going to do is there were some resources that I want to make sure to put in there. Here's the non-pharmacologic interventions from the AHRQ. I'm putting that in the chat now. Let's see if I can stop sharing.
Any questions, comments?
Any questions for Dennis or Amy?
Has this been helpful to you? Because we always ask that.
Dennis, I wanted to ask you if you or Amy know of nursing homes that have done the age-friendly initiative and how it aligns with this.
We have not worked directly with anyone, but the age-friendly, some homes have done that with the 4 M's. And they've, you know, it's just another path to follow. So.
Yeah, I think I mean, I've used it in the hospital setting. So that's why I was asking if people have done it in the nursing home, because I think it does provide some guidance. It does provide some, and you mentioned it as one of the references.
Yes.
And it can help to simplify a few tasks.
Yes.
You don't have to do the whole shebang to be successful if you do little tasks at a time, one unit at a time, one group at a time, and work at that.
And next week, we're going to, Amy and I had worked very closely with a 500-bed facility in the Bronx and with psychotropics. And next week, we're going to kind of explain to you guys how they started and where we ended up and kind of how we made that journey to where they are now off and running, doing 2 GDRs successfully every like 2 weeks. And really, you know, they're doing very, very well. So.
Wonderful.
And we're always here, you know, every one of us to support anybody with anything.
Excellent. Thank you so much. So I did put the links to the AHRQ and the iPro resource library into chat for those who are interested. And one last chance for anyone who might have any other questions for Dr. Lynn McNichol, Dennis, and Amy. All right, well, that should be it. If you thought that today's session was helpful, please let us know into chat. That would be really helpful for us, as it does inform our future content. So just let us know if you thought today's session was helpful or not. It does mean a lot before you go.
See you next week.
Thank you, everyone.
All right, thank you so much, everyone. Appreciate it. Have a good one.